Hello, and welcome back to the THET 2021 annual conference, The Power of Partnership, Solidarity in the Shadow of COVID. Great title. And it's an apt title for our session now, which reflects on the great leveler that shocks to health systems can be in exposing the weakness of the strong and the strength of the weak in many cases. And the events of the past 2 years have really provided limitless case studies in the importance of solidarity and the connectedness of health systems. Healthcare has a responsibility to be the first man, the first person standing back up again after a major shock or a tragedy like a pandemic or a natural disaster or a conflict. And as a global health consultant myself that works in high, middle and low income countries alike, I can tell you that the topic of resilience is on everyone's lips now. It is the watchword in every continent, spawning thousands of strategic reviews and inquiries, new guidance, new laws, new investments, all explicitly geared towards working out what the hell just happened. And how the health system performed and how health systems around the world can respond better next time, as well as coping with the aftermath that we face now. So this session explores the theme of health system resilience, looking at 3 examples of systems coping with different kinds of shocks and their responses to that. I'll let our speakers for today give a more erudite and comprehensive definition of what resilience means to them, but I'll just frame our discussion in the most practical definitional terms that I know of, which is the Mike Tyson definition of health system resilience, that everyone has a plan until they get punched in the face. And the past 2 years have been a humbling experience for many health systems that thought they had nothing to fear. Areas of our systems we thought were strong locally or nationally or globally turned out to be weak. And in some cases, the things that we took for granted turned out to be our greatest strength. Now, I'm sure I don't just speak for myself when I say that we're in dire need of some perspective about what's just taken place these last 2 years and what it means and what we should be doing now as a result. So another saying, this time I think not from Mike Tyson, is that generals and armies always prepare for the last war rather than looking to their future threats. Now we're going to cover pandemics in some detail today, but we also need to think carefully about the lessons that we're hearing and what healthcare's next war is going to be. Is it going to be climate change? Is it going to be a bioweapon? Is it going to be a cyber attack? Or is it going to be the slow grind of a health worker and funding crisis? And that's why we've selected the 3 speakers for today to demonstrate resilience or lack thereof in 3 very different contexts and circumstances. The agenda is really simple. We're going to hear from 3 speakers for 15 minutes each, and then we're going to have 20-25 minutes for you to ask questions. And the best questions are the ones that you think of at the time, not at the end. So I'm going to encourage you, as they're speaking, to go to the Q&A button that you'll find on the right of your screen, I think, and type in questions as they occur to you, and then we'll field them. We'll field them all at the end. And do write in if there's a particular speaker you want to direct a question to, who you'd like it to go to. The only other button I'll just point out to you is if you're having any bandwidth issues. One of the great things about this AirMeet system that THET have chosen is that it gives you the option to switch from HD to low bandwidth to give you a slightly smoother listening experience if you'd like. So our 3 speakers today are Alistair Ager, Director of the Institute for Global Health and Development at Queen Margaret University in Edinburgh, who's going to present on health system resilience and challenge in internally displaced populations and refugees, particularly in Nigeria and Syria. Then we're going to hear from Peter Weiswer, the Associate Professor of Health Policy Planning and Management at the School of Public Health in Makerere University in Uganda. He's going to talk about how the Ugandan health system has responded to COVID, thinking about recommendations for future resilience and also the role of health partnerships in that. And then Sansan U, Associate Paediatric Specialist in West Wales and co-founder of the NGO Better Burmese Healthcare, and leader of much of the RCPCH's work in Myanmar over recent months. And she's going to perhaps give a less positive story about the strides made in health system resilience pre-coup in Myanmar and the response to COVID, which that enabled, and then how, to some extent, the coup has broken that system down, but the inspiring role that our colleagues and health workers have been playing in that in Myanmar. So we'll do questions at the end, as I said, and do please say who your question is for. Without further ado, though, I'm going to introduce Alistair Ager, who, as I said, is a director of Institute for Global Health and Development at Queen Margaret University in Edinburgh. He has worked in global health and development for over 30 years as a consultant, basically everywhere, doing research and consultancy work in sub-Saharan Africa, South Asia, the Middle East, Europe, North America, and with every agency that it is worth having on one's CV as a consultant: UNICEF, UNHCR, WHO, Oxfam, World Vision, Save the Children, Islamic Relief Worldwide. And he also served as Deputy Chief Scientific Advisor to DFID from 2017 to 2020. So Alistair's going to present on health system resilience in internally displaced populations and conflict, refugees in northern Nigeria and Syria. I'll hand over to you now, Alistair. Go ahead. The floor is yours.
Thanks, John T. Well, and thanks to FET colleagues for setting up this particular session, a really important issue. And John T., particular thanks to you for very apposite comments, I think, and I think a number of your framings will be referenced, certainly in my presentation, and I suspect others as we go forward. So Ed, if I could have the presentation up, I will start speaking to that. In terms of shocks that John T mentioned, I'm very much focusing on two particular shocks, two particular settings in northern Nigeria in relation to the Boko Haram insurgency and actually the counterinsurgency with respect to it, and the shocks to the health system, particularly in Yobe State. We're presenting on that, and then building on that, talking about response within Syria, particularly within UNRWA, to the provision for refugees, Palestine refugees based in Syria. Both of these papers are published that I'm referring to, so I very much encourage you to look at those to follow up if you found this of interest. But the key thing is trying to draw out lessons about resilience and something around a systems approach to understanding the various elements, the complex elements involved in a truly resilient health system. So have the next slide, please. So this is the first analysis. It's about getting on for 10 years old now. The insurgency still continuing in the northeast in many ways, but this was looking at the early stages, particularly in Yobe State, and in particular understanding how the health system at local government area level, LGA area level, as well as the central hospitals coped, particularly with internal displacement. So there was the insurgency, but the insurgency was leading to large population movements within the state. And you'll see a couple of graphs of how a health system tracks the needs and the movement of its population that it's seeking to serve, as well as, in the context of displacement, the displacement of health workers themselves. Next slide, please. So you'll have seen that this is using what's called a group model building approach. If I have the next slide, I'll go to that. So this is just showing Yobe State in the bottom left-hand corner in the northeast of Nigeria. The LGAs, the different areas that were affected, some much more affected than others, is shown in the top left. But the main reason for showing this figure is something of a flavor of the approach, which is in starting in the top right-hand corner, talking with individual health workers in the broadest possible conception of that. So not just doctors and nurses, but also clerks, security guards, and others key in the health system in terms of its functioning, to describe how the situation was before the insurgency, how they responded to the insurgency, what the impact it was on their work and the way they responded, and then as things began to resolve a little, what the situation was there. And the dynamics, the shaping over time, is a really important part of this approach. And I think it's an important part of understanding that resilience is a systems process over time. It's not a one-off event. It's a response to changing circumstances. And so a time series approach and understanding how things changed and how the response changed is crucial to that. And the other two pictures there shows that various ways of negotiating, formally the term is scripts, but ways of working with groups of health workers within a system to understand the challenges that they faced and how they responded, and to begin to build a map, a systems map of that, which is what's happening in the bottom right-hand corner, of convening people to try to understand all of the factors that were shaping their experience. Some of those factors the doctors would know about, some of it the clinicians might know about, some of the planners might know about other things, some of the clerks might know about others, and to negotiate a shared account of how all of those factors were coming to bear on how the system operated. Next slide, please. This is not a particularly easy slide to read, but there's a triptych here. There's 3 images here, and it just gives that idea of dynamics. And there's no words on this page. It's called the rich picture. And this is asking fairly senior people who are initially a bit embarrassed to do this, to draw a picture of what the situation was like in the early stages of the insurgency. And you might just see in the left-hand side of the image a church with a cross on it that is being burned. And you'll see some disruption of populations. Then in the middle panel of this, we have a mosque being burned, and we have crops being burned. We have motorbikes being banned because Boko Haram were using motorbike assaults to affect communities. We begin to see broader community disruption. We see that how that's affecting clinics. And on the right-hand side, we see some further response to that. This is just a way of getting health workers to reflect, not just too much in jargon or labels, about what was happening and how the response evolved over time. Next slide, please. Also, we can use data. Here on the top figure, it's outpatient attendances, and we're looking at 3 LGAs, and we can just see the huge fluctuation. There are other figures coming up later in this session from other presenters looking at health service utilization over time, and it's a crucial measure of health systems resilience and how we understand it. So you can see in some LGAs an increasing burden, in others a decreasing burden, a fluctuating burden, and deliveries is actually the image at the bottom. And you can see huge fluctuations from no deliveries available at all within an LGA to suddenly an LGA now having a high level of deliveries with the displaced population from elsewhere. Next slide, please. So we feed this into an analysis. You could just give a click, please. And this is a deliberately complicated figure, but these are all the factors that health workers came to consider had affected the response. And you might see insecurity in the top of the figure. And in the bottom right-hand corner, you can see healthcare quality. That's one of the key things we're interested in. So essentially, we're asking the question, what were the problems of delivering healthcare quality in the context of the insecurity? First click, please. So this was one of the pathways of threat. Insecurity was leading for the migrations of people, movement difficulties, restrictions. That was leading to either high levels of utilization of health services in some areas, low levels in others. That was putting pressure on health infrastructure and affecting healthcare quality. So that's one pathway of threat, if you like, that was having to be responded to. Next click, please. But there's another pathway. It wasn't just getting to the clinic, it was losing health workers. There's this really important pathway to understand that we see here, not just a loss of non-indigene Yorubayans from the health service to other states, but we also see the exit of many services and programs from international agencies, which not only reduced service provision, but it reduced the supervision available for staff, etc., creating greater health worker workload and obviously affecting healthcare quality. So those two pathways are the threats, the challenges. Next click, please. What was the response? Well, political will was mobilized, and quite importantly, increasing liaison with security so that ambulances could more reliably get to facilities. It also encouraged HR recruitment with packages, including latterly insurance packages for death in service, which actually encouraged migration into the state. That's the left-hand side. And a prior commitment to a free drug supply program meant that what would have been otherwise huge challenges around drug procurement and availability were reduced. So there's a mobilization, a part of the resilience was a mobilization of political will to do those things. Next click, please. But very much in keeping with that theme of solidarity, there was significant involvement of community resources that were engaged. And this also improved liaison with security, encouraging communities to be able to evacuate pregnant mothers in labour in more safe ways. It also mobilised political pressure. The political will didn't come from nowhere. There was actually significant pressure from community organisation and civil society about challenges at the morgue and in terms of protection of health personnel. So there was significant evidence of resilience through community action to mobilise political actors. Next click, please. And finally, in this image, you can just see that little orange thing about staff. It's essentially staff solidarity, that there was a response from the staff, both in terms of working longer duties and task shifting. Task shifting had been quite a political challenge, but was actually facilitated significantly in this environment, with staff taking on new duties and able to sustain and support healthcare quality. Next slide, please. So that gives you a feel of that approach. And then from a number of studies, we began to identify, this was early work, 4 characteristics from some of those early studies. One is what we call collateral pathways, but it's just really more than one way of doing something. If there's more than one way of delivering drugs, or more than one way of getting staff to a clinic, or more than one health worker that can deliver a particular service, there's clearly a redundancy there, which is hugely protective. We found that health systems, not just the one in Yobe, often narrowed their focus and on a key priority issue and decided to put resources to sustain a high level of quality in provision in a key area, acknowledging the need to deprioritize some other services. Storage capacity, that sort of little battery sign, was a reflection. The most obvious tangible thing was drug supplies, of finding ways of, when roadblocks were lifted, being able to move drugs and appliances, not necessarily to the clinics, but to places where they could be safely stored and then subsequently accessed when other roadblocks were lifted. But more generally, we saw a storage capacity in the goodwill of staff and the potential for staff to be able to endure potentially months of non-payment, common in these situations, if there was a sense of confidence that ultimately that payment and remuneration would be made. And a final point there, this alignment of motivational interest, this sense that commonly is observed that in times of crisis, there was a sense of being able to create clarity and unanimity of purpose, which other times had been challenging. Next slide, please. So I want to very briefly show how some of these things came out then in a subsequent study in Syria, looking, as I said earlier, at the response of the UNRWA health service, and you'll see the same sorts of ideas and the same sort of approaches coming out. Next slide, please. The same methodology used. So here we have interviews, we have people drawing a rich picture of how they had responded as the Syria crisis and the siege of Yarmouk continued and were then relieved. And this way of working pictorially, we find just frees staff of different statuses and levels to talk something about their emotional and vivid experience, which is then a huge resource for then beginning to work together to decide how did we cope, how did we respond, as Jonty was saying earlier on. There's that graphic images of what changed over time, what went up, what went down, what sequence of this. You can see the deliberation around this, and in the bottom right-hand corner, beginning to develop one of these systems diagrams. Next slide, please. Now, the next 2 or 3 slides, this is now a more advanced but confusing picture of the threat. This was the pathways of threat that health managers in Syria and Damascus were needing to manage. I'm not going to go through that in detail, you can look at it. But it shows something of the complexity, whether it's the electrical systems and water supplies, whether it's staff availability, whether it's pharmaceuticals. This is the reality of being a health manager in that context, of all of the drivers of challenge. Next slide, please. But we were wanting to much more vividly map the responses to that. Now, again, this is too small for you to see in detail. If you go on to the next click, we make it a little larger, just looking at one section of this. And you can see here various pathways of response that were led by health personnel within the UNRWA service that we could trace. And you can go to the paper to see the detail of it. But I want to highlight the colours here work in a slightly different way. The orange thing that you can see in the bottom left-hand corner is again around task shifting, staff pressures, the way that was worked. We would call that an absorptive capacity. So that the health system was set up in a way that the health staff could be deployed in a different way, deployed into slightly different roles, and that could be absorbed by the way that the system was set up. Most of the other arrows there, though, are green, which is basically an adaptation of the system. The emergency plan was inadequate completely for the response. It was anticipated for a migration of 5,000, 10,000 refugees, not 100,000 refugees, of a duration of a few weeks rather than a few months. So all of those green lines are indicative of variables that managers adapted and changed over time. And then finally, the purple lines are what we call transformation. It wasn't just adjusting the system, it was substantially changing it. The next slide, and I'm nearly at my end, thank you. So these are those three ideas: absorption, adaptation, and transformation, which has become, Carl Blanchett has also used this framing, a good way of thinking about a sort of a more minor, the capacity of the system to absorb, the adaptations that are required to cope with shocks, but in some circumstances, then the complete redistribution and restructuring of a system or resources in a transformational way to deal with shocks. I think I'm coming to a final slide next. Thank you. This systems modeling, though, also, as well as showing the complex pathways that people are managing, a final slide here is just indicative of a key thing. This is a part of that diagram, and it's showing that the little B1s, B2s, and B3s actually show feedback loops. In systems thinking, these are key things that can either be vicious spirals of deterioration or virtuous spirals of strengthening something. And they're related to adaptation and development of clinics, support of staff, etc. But the key thing that links all of these elements is clinic area and field office decision-making. And central to this was not just the ability of staff to make adjustments, but it was also the latitude they were given, the authority they were given to make changes day to day, week to week, month to month, without which there would not have been the resilience that was shown within the health system. Thanks ever so much, Ed and Jonty, and I think that's me done.
Wonderful. Thank you, Alistair. A great presentation there for visual thinkers like myself, and a lovely background to see you there with a nice Matisse as well. Lovely thing for visual delight as well.
It's a copy of a Matisse, I think.
Oh, is it? Okay, well, Edinburgh obviously doesn't pay quite as well. That's great. Thank you for that. And there was a famous saying about those system dynamic slides with all the arrows in the Iraq War, that when we've understood, by the time we've understood this slide, we'll have won the war. But actually, I thought you did a fantastic job of describing. I think for the first time, I've understood a system dynamic slide and how it can work and how powerful it can be. So do put any questions for Professor Aja in the Q&A. Really interested to hear about some of how you communicate that to makers maybe, and turn that into something they can act on. But for now, so do pop those into the Q&A as we go. For now, though, we're going to switch to a very different context and topic with Dr. Peter Weiswer, who is an Associate Professor of Health Policy Planning and Management at the School of Public Health in Makerere University, Uganda. Peter is a leading global health academic involved in local, national, global policy making and implementation. He leads the Makerere University Maternal and Newborn Child Health Centre of Excellence and the in-depth network of MCH research. He's a member of Uganda's National Immunisation Technical Advisory Group, which has been doing a lot of work on COVID-19, of course, as well as the WHO Strategic and Technical Advisory Group of Experts, STAGE, for MCH work. And Peter's going to talk to us about how Uganda has responded to the challenge of COVID-19, with particular reference to maternal and child health, and reflections on what that means for health system resilience and health partnerships. So over to you, Peter. The floor is yours.
Thank you so much. I hope you can hear me very well. So I'm going to be speaking about the topic which is already presented around how has the system in Uganda responded to COVID-19. And I think the previous presentation makes a good case and the preparation for my presentation. So as you might know, the pandemic has taught us that health systems are very important. But in order to be important, they have to be resilient and they need to be systems that learn. Health system resilience can be defined as the capacity of the health system, one, to prepare for, but also to effectively respond to crisis and to be able to maintain its core functions when a crisis hits, such as COVID. And they are informed by learning, and they should be able to protect human life and produce good health outcomes. Now, in Uganda, we, of course, just like elsewhere, one of the major things that happen in Uganda is lockdowns. We had the lockdown just even before we got the first case of COVID. You can say this was the fear factor that led to the lockdown. And the lockdown, that went on for a couple of months, from April 2020 for about 3 months. And then we also had a second lockdown early this year from about May to July, when we were hit by the Delta variant. During the lockdown, almost everything stopped. Especially the first lockdown was quite severe, where no movements were allowed, public transport and private transport was not allowed, and there was a curfew. The army and the police were involved, and sometimes they are quite, actually, they were harassing people, and a few people were actually killed by the army. In fact, we always say that in the first wave, more people died because of the security forces than the deaths due to COVID. So fear was a leading thing for what happened in Uganda. And I'm going to be showing you a couple of slides to show how did the system respond. I'll start with the outpatient utilization for children under 5. As you might see in the graph, things already fluctuating, but after, from where we see the red line, the systems almost collapse immediately after that lockdown. And in the second graph on the right, we see the decrease in the OPD utilization, outpatient utilization, immediately.
Just to interrupt, Peter, we're only seeing the slide before that, so you might need to move your presentation on so that people can see those two graphs.
No, it's on the same graph, the one with the green bars.
We're currently at the title slide, your first slide.
Can you see that?
We are still seeing the title slide.
Oh, so maybe could you present the slides?
We can have Ed take over the screen share. Is that okay, Ed?
Okay, thank you.
So we're on that second slide with the two graphs.
That's fine. Thanks, Jyoti. I'll do that.
And my apologies on that. I'm trying to run the system. So as I was saying, that our response started by fear, and the fear was instituted a couple of activities. Let's go to the second slide. Here in this slide, we see what was happening with outpatient utilization of facilities in Uganda across the board. And what we see that from the red line, once they had instituted the lockdown, the outpatient almost collapsed because people could not move, even health workers could not move. And here in the green graph shows what the drop in outpatient, which was happening month by month. Over the period for this data, there was a 44% drop in outpatient utilization. but we didn't have home care. So where were people getting healthcare from? Next slide. So here is a map basically trying to show the outpatient utilization during the time of COVID. And in the first, we see that from the first map, there is a bit of the green shows that outpatient was good, and the red shows basically the disruptions that were happening. And we can see over time from these graphs that it became red, continued to be red for quite some time. But later on, after the system started responding, was learning, then the green started coming back. And at the end, in the second lockdown, as you can see in the last map, which was the second lockdown, although the system is meant to learn, it again outpatient dropped almost completely across the board. So it's a system that was trying to learn, but again struggling to resume services. Next slide. And this slide shows utilization of childhood vaccinations. And I wanted to interest you basically in the graphs are all the same, but the main one is the graph at the bottom on the left, which basically shows the utilization of the pentavalent. And over time, we see that the drops continue, although they never went back, they never went to zero. They're almost dropping to a level of what was happening before. But there were some significant drops that were happening month by month. And up to now, actually, immunization has not gotten back completely to the levels before the pandemic. This is the same for other vaccines like OPV, BCG, and HPV. Next slide. So again, this is another way to show in a map. And the red shows that the services are being disrupted. The yellow, the disruption, and those were severe disruptions, whereas the yellow were moderate, and green were a system which was trying to perform as before. So from here we can see from pentavalent, from the beginning, it was already there were some issues, but then the second map shows it became quite severe disruptions of immunization services. And with time, they tried to come back, but not completely. And up to now, as you can see in the last map, there are still areas of red and also green, meaning that the system, although it's responding and trying to get back, it has not come back completely to where it was before. Next slide. So I just wanted also to show essential medicines and the supplies, because medicines are quite important in the health system. What we can see, interestingly, that the system was able to maintain the availability of medicines, the testing services, almost at the pre-pandemic levels. So this is a good response by the system in terms of those things they could deliver. But when they involve communities, it was a little bit problematic. Next slide. So in summary, we can see that we've had mixed results where services are disrupted, but the system sort of responds. What drove this kind of system that we see? One, we have previous pandemic experience. We are a country of outbreaks of Ebola, HIV, malaria, cholera, and we already had a lot of systems in place and learning from what was happening before. That learning was used actually for COVID to be able to mobilize services and also to mobilize partners. We already had an existing system for engaging partners at national level. But because of the severity of COVID, the shock of COVID, the fear of COVID, the cohesion of the partners even became stronger, both at national level, but also at subnational level. And there was also timely response in terms of funding from the government, but also from partners such as the Global Fund, from Gavi. They were able to change some of the money to be used for COVID response instead of just HIV services. And also there was a whole of government response, which was quite interesting. We've been struggling to get government to engage more in health service delivery. It has been mostly left to Ministry of Health, but during the pandemic, the whole of government, basically led by the president, the cabinet, parliament, and at the sub-district, the sub-national level, also similar structures and partners and communities were able to come on board and be able to respond to COVID. Then use of routine data, as you've shown, we virtually, on a weekly basis, we're able to look at how is the system performing, and this is presented to partners, and the people are able to respond at the national and at the local level. And one of the positive things that happened was the local academia was actually quite engaged in the process of the pandemic response to provide evidence. Then partnership at implementation level, especially at the district and the regional level. Partners of all types, small CSOs, NGOs, big ones, were able to work together to ensure that service continuity is maintained. And the communities were brought on board. This is one of the things which was quite important. When people stopped coming to hospital, to health centers, the government was able to mobilize community health workers, although this was done quite late. But now they are quite involved, and they have developed new models of service delivery during the pandemic. Would they be maintained? We shall see. Next slide. This is my last slide, and I just want to summarize what was going on. When the shock came, next, please click, sorry. When the shock came, what happened? I can't see the animation, please click. So when the shock happened, the governance, the whole of government at all levels came on board, and they were able to lead the response. Next. This, one of the most critical things was around how do we maintain services? Next. And the information systems, data of all types collected from the regular system, sending people out, social media, etc., and the pressure from communities also helped. Next. And of course, as you've seen, the medicine availability was assured as much as possible. Next. And this was able to maintain some quality of services, although we've had issues of excess deaths. Next. And of course, trying to involve people. This is something that the system is still learning. How do you involve people so that it is not just an bottom approach? This is one of the challenges of the response that we are still witnessing. Next. So, in summary, we see that in Uganda, the system was able to learn and do some response, and in general, the system never collapsed and has been able to do some learning and continue service delivery. Whereas we are going to have excess mortality, I think it is not going to be as bad as had been predicted. Thank you so much.
Wonderful. Thank you, Peter. Some more highly skilled use of arrows there. That's what I'm taking from our resilience discussion today. It needs lots of arrows, but it's so interesting to hear the perspective of a country like Uganda, where the sample size of previous pandemics and how you respond to them is not 1 in 100 years, but it's what, 5 in the last 25 years. So the experience and the resilience that's been built up through those experiences with HIV, with Ebola, with cholera, with malaria, is so interesting to see how that fed into the experience. And I thank you for the candid experience which you shared, which didn't ignore the human cost which has occurred, but did also focus on some of those positive aspects that maybe we can pick up in the questions around, the legacy that it's left of, much better routine data at local service level, which is really interesting about how that will play into other things, and also the people may wish to ask a little bit more about the vaccine rollout as well. So I invite those questions all using the Q&A function that you'll see on the right. Do write those in while they are fresh in your memory. But for now, we will turn to our last speaker, Dr. Sansan U, who works as a associate paediatric specialist in West Wales, but really her passion is also in Myanmar, where she co-founded a local NGO, Better Burmese Healthcare, in 2005. She's worked since 2015 as a clinical advisor to the Myanmar Emergency Paediatric and Neonatal Care Programme, which is the partnership between the Myanmar Paediatric Society and the Royal College of Paediatrics and Child Health here in the UK. And she's also won a BMJ South Asia Award for Excellence in Medical Education for that work. She's been intensely involved, obviously, through the crisis that has been occurring in recent months, and so is going to give us a background first of the healthcare system in Myanmar and the successes of the work that was done there prior to the coup, the effect of the coup on the health system, and how that contrasted their experience with COVID afterwards, and talk about the incredible role that our colleagues and health workers have been playing in reacting both to the pandemic and to the coup as well. So I'll hand over now to San. Go ahead. The floor is yours.
Thank you very much. And first of all, I would like to thanks for giving me an opportunity to speak. And my special thanks go to Royal College Global Health and Marcus, who helped me to with the technology and support and help. First slide, please. So I would like to talk a little bit about a background of Burma. I will refer as Burma. Please don't get confused. We are talking about the same country and the same place in the world. Yeah, this is the next slide, please. This is the quote about Burma by Rudyard Kipling. He is 1800 English journalist, writer, and poet. And this is his quote on Burma. He said, "This is Burma, and it is quite unlike any land you know about." So that was 1888, and it's still true to this day. I just want to spend a few seconds explaining about Burma. After we got independent, and Burma is the richest country in the Southeast Asia, and rich in natural resources and rich in human resources as well. We have high literature rate and highest graduate per population, and we have the best potentials among all the independent country. Unfortunately, Burma has been under serial military dictatorship since 1961, and the healthcare investment is 1% of the GDP. So you can understand how fragile and under-resourced healthcare systems Burma was under. But after the 2015 election, Burma gained a quasi-surveillance government in 2016. That's when we modernized to catch up with the outside world. So when, next slide, please. When COVID hit Burma, so we managed to withstand this pandemic with mainly coordinating between the CSO and NGO and with their innovative measures, and we escaped first and second waves relatively unscathed. We have a lowest number in the region, and we were the first country to introduce the vaccine program. Although we did not have advanced, track and trace systems and surveillance systems, with the sheer cooperation from the NGO and public and innovative approach, we managed to contain and control the infection. One of the measures to contain was the isolation quarantine, and all these isolation quarantine centers and all these fever clinics are mainly run by volunteers and the donations from the public. Next slide, please. So our first reported case was on the 23rd of March from the travelers from America, and the countries say stay-at-home order. So, but like any other country, stay-at-home order, the collateral is that the attendance to the hospital is drastically reduced, both neonate and pediatrics. For that, Royal College of Pediatric and Child Health, in collaboration with UNICEF and Burmese Pediatric Society, we began to support the hospital care for the babies and the pediatric by increasing and upgrading the essential respiratory support and wash supply. And we run a lot of virtual technical support and teleclinics and virtual support, and it's happening regularly. Next slide, please. So this is the graph showing the 2019 and 2020, the same time, exact same time hospital attendance. The dotted line being the 2019 and solid line is 2020. And the violet color is a neonate. So when you look at this, neonatal attendance is traditionally low because in Burma, the birth happened majority of the birth happened outside of the hospital rather than in the hospital. So you can see that it's a big gap between 2019 and 2020 hospital attendance. And like my previous speakers, there is an increase in delayed in seeking the help and increase in the death rate. Next slide, please. So unfortunately, early hour of 1st of February 2020, another military coup happened, and people are outraged. So they adopt the non-violent protest called civil disobedience movement, refusing to work under the military regime, and the people say what we call is no campaign. They are not doing what they were told to do. So we have a big border with India on the west side, and when the Delta wave hit India, few weeks after that, it came to Burma. But unfortunately, because there is almost total collapse of the healthcare system under the military regime, and these cases are not diagnosed, and there also surge in the hospital, help come to the hospital, but hospital could not provide what the patients need, and there's not enough capacity to cope with that. On top of that, military monopolized the oxygen supply and the drug supplied. Next slide, please. So this is the death reported to the WHO, and although there is a surge there, it is very much underreported. The report comes from the military hospitals, from the military personnel. So at Miney, this is so much underreported, and it doesn't reflect whatever on the ground. Next slide, please. So this is the estimated oxygen need. So this is a big surge in early June and July, and we did not have oxygen. This is the estimations from the WHO, but there is no oxygen for the public, almost none. Next slide, please. So this is the testing capacities reported by the military. So as I said before, it is the military hospital from the military personnel. So you can see the testing capacity did not increase along with the increase in the incidence of the pandemic. Next slide, please. So this is a quote from Ms. Young Healy, who was the former UN Special Reporter on Burma, about the situation in human rights. She said, Hunter is weaponizing COVID-19 for his own political gain by deliberately fueling a humanitarian disaster. So this humanitarian disaster is not only because of the COVID, because of the atrocities and the cruelty from the military, and people are moving away from what they normally live because and together the doctors and nurses are hiding or running away from the arrest and detention. So we also have a climate disaster during the monsoon. We have a lot of flooding and landslide, which the outside world did not know, and a lot of death, but we are suffering in silence. And apart from that, people are moving away from the town and the cities towards the border area, and there's a massive IDP and makeshift refugee camps, which are, along with that, there's a lot of health crisis with the conflict and the IDP and natural disasters on top of pandemic. So next slide, please. So this is nearer the end of my talk. And in summary, in pre-coup, we have very fragile healthcare system, but we can respond in an innovative way to emerging threat, and we can control the infections. And however, the need of the political leadership is a key for any healthcare system response. The tragedy of death toll in Burma and for the third wave following the coup is the proof that point, and it served the warning to the rest of the world. With that, I paid tribute to the healthcare personnel inside Burma who are giving the healthcare under the challenging, unbelievable conditions, and they have my utmost respects. Thank you for listening, and that's the end of my talk.
Thank you so much, San, for that very powerful and moving description of how things have gone. Sadly, not positive in so many respects, but such an inspiring story of how you and your colleagues have responded. We are bang on time, thanks to the professionalism of all of our speakers, getting it right to the pips. So we have a good amount of time for questions and answers. So do write those into the chat as we have a good amount of time for them. What I'll do is I'll perhaps start by just going in the order they originally spoke and asking one question that we have for each of our speakers. So starting with Professor Ager, I'll merge two if that's okay. You answered an excellent one from Agnes, and there's a similar one from Alex, which is really around. So you've created this incredibly rich picture through the modeling and the system dynamics tool. The question from Agnes, which was really around kind of how do you then turn that into something which is sort of used in action? Because I would imagine sitting down with that tool as it is in its raw state with a very, very stressed health system leader in that area would be maybe not the best way of going about it. So how do you sort of turn that into a tool for action? And then Alex's question, which I suppose is sort of related to that, is kind of outside of those specific contexts, are these sort of models of absorption and adaptation and transformation, can they be applied to non-conflict settings? And his example was in the NHS, and whether something like that can have a role there. So do you want to give us your thoughts on that, on those sort of two related questions, and then I'll ask one of Peter next. And you're on mute.
Yes, happy to, John, too. So the method, first of all, or that process, I think it's hugely helpful. It's not a panacea. As a researcher, it frustrates me that a lot of the insight that's reflected in the room in the discussions is not captured. That it's great to have people, arguing over a picture and this sort of thing, and it's actually quite difficult to always capture the richness of the discussions and sometimes the contestation about, well, no, actually that was before that, and this was a more important factor. So I'm not suggesting it as a ubiquitous model, but it's hugely helpful for a couple of reasons, and linked, I think, to, it doesn't have to be heavy trauma situation. I think it's a situation where people have been through something together, but they have different perspectives on it. And it's a way of negotiating a shared account of what happened and how did we, a plural we, respond. And by using the pictures and by using the graphs, it somehow gets people out of jargon into just some sort of, say, joint negotiation. And as I put in the chat, actually in both of the situations I described, there was quite a profound sense of gratitude of participants, of thank you for helping us tell our story, perhaps particularly amongst UNRWA staff in Syria. That just to listen and to help the account be constructed was something like, we're modelers, we don't write the story, they write the story, we're helping them tell the story. So I think there's a huge, not just in situations of trauma, but it's a useful method for helping people articulate what they've experienced and how they've responded, and to have that validated when it has been challenging. So even, UK NHS, I think as a debriefing method, it can be quite helpful. But more importantly, it's not just that, okay, this is what we did. It is, as I think another couple of questions prompted, the attraction of that model is really saying, okay, there's all sorts of things happening here. Where are the key points, the leverage points, where we could have done, if we put more resource in there, we could have handled this better, or where's the biggest weakness? And so that's often how we use it, not to try and do every pathway, but to actually specifically get people then to use it almost like a menu. And we've used it in Ghana in some field work with communities coming together with health workers in terms of the scale up of CHIPS, for example, the community health services provision of, okay, it's not quite worked, but where are the 2 or 3 things where we could have done better? So I think as a diagnostic, it is also hugely useful. Then to link that to the absorption, adaptation and transformation, again, it's not a mystical threesome. It's useful language, though, to get a sense of degree. I think absorption is important, and I think clearly our planning needs to be what would happen. We can anticipate certain shocks and how we could absorb them, in terms of our staffing roster, in terms of our drug supply line. We need to think about absorption. But the adaptation, which is clearly so strong, required in the settings that we were looking at, suggests that what was needed as a resource was also the ability to change your mind, to develop a new structure, to hire a new way, to have a per diem staff coming in, to reroute things. And that adaptation is, I think, a useful it's a useful step away from just absorption. Absorption you can plan for, adaptation you can also plan for, but you need to give people license and competence to be able to evolve their thinking. And then ultimately, I guess then transformation is if the structure is so ill fit for the new purpose, the emerging in context, to have to see, as again, I think other couple of comments said, that crisis can encourage us to rethink the whole thing, to say, okay, there's a whole thing we've missed out here. We need to transform the way we think about this rather than just adapt an old model. I hope that answers those questions, but that's great. Thank you.
Thank you, Alistair. Great. I will turn to a question for Peter now, which comes from Louise, which is that, as you shared, Uganda has a lot of valuable learning to share with other health systems about how it has managed COVID. And the question is sort of, have other countries been keen to learn, and what do you think some of those lessons might be for other countries that came to learn from Uganda? And I suppose I might shoehorn in as well there Alistair's challenge of sort of, within all that complexity, what are the 2 or 3 things that Uganda has learned that maybe it will do, the next time that it faces something like this? So I'm going to throw that one in there as a free. So Peter, over to you.
Thank you so much. I think the basic challenge is whether the learning during the pandemic can be sustained, because once the precursor, which is the pandemic and all this global interest and local and the community interest goes, there is a risk that the system can go back. You actually asked me about the rollout of vaccines, and I said I sit on a night. We had a meeting just before this, and one of our concerns is that we have a lot of vaccines now. We have every single vaccine you can think of. We have Pfizer, we have JJ, we have Moderna, we have AstraZeneca, we have Sinovac. And the challenge right now is actually convincing health workers to vaccinate, because they are saying we need to be paid. So before we had a mad rush for vaccines, everybody wanted them, but now they are here. And by the end of the year, we are going to have more vaccines. One problem we have is that a lot of the vaccines we are being donated from Europe actually expire like always within a month or two. This is a problem to take back to Europe. So that's a challenge. So what should do the system? What have we learned that is important? I think the importance of the whole of government coming on board is important. Going beyond the health workers is an important step. Health workers, we like being in our safe place, which is clinics and stuff. But a lot of the other things are politics and community and money. We are not in control. So for me, that is an important part of the response. The second one, the importance of partners, especially coordination. Usually they are quite fragmented and everybody going their way. COVID sort of mobilized them towards a common enemy, mainly because I think for the first time, even those who thought they are not vulnerable, they felt that COVID makes everybody to be vulnerable. Before, it was an issue of the poor because the rich could go to private healthcare or they could fly out. But when the borders were closed, then healthcare became everybody's business. The third one is actually for me, which I like most, is the use of routine data. And this has been quite an important learning. And I was impressed for the first time. I was happy to attend a meeting of the Ministry of Health regularly every Friday, and they present a summary on almost of the entire health system in terms of its functioning, including getting data from the private facilities. Then they would use that data to actually respond. So for me, and maybe a final one is sort of the self-dependence. You know, COVID, the shock that it gave us, we had a lot of people from the West here. Most of them went home, and everybody knew we have to do it ourselves. So they mobilized internal resources, try to use the local academia a lot for technical assistance. And then the government has started investing. They even want to manufacture vaccines. So I think those are some of the issues of self-reliance coming together and say, I think we need to do it ourselves.
Thank you, Peter. It's really, really interesting. Great. We will turn now for the question for Dr. Wu, and I will again try and merge two that I think have similarity here. So obviously the UK, and you spoke about this, has a rich history of health system partnerships with Myanmar. There are several of them, and to some extent they were slightly more protected than other cuts that were made in our aid spending, which was great. But the two questions we have are really about collaboration with other actors. So that there's one asking for your opinion on how WHO collaboration might help the Myanmar community, both with COVID and of course with the military coup, and then another one focusing on neighboring countries and how, you know, obviously the neighboring countries of Thailand and China and India might be also able to better partner with health system efforts there. So either of those that you want to respond to, Dr. Wu.
Thanks. Thanks for the question. I will respond to the second question first. You know, we border with Thailand, Bangladesh, India, and China. So through Thailand, there's a lot of refugees and internally displaced people dotted along the Thai-Burma border. There is a huge influx of the people running from the central Burma towards the border, but because that we have unchecked, undiagnosed Delta wave or maybe unknown mutations because of this, nobody's checking. So Thai government closed the border, so nobody is allowing to cross border. However, there is an existing famous clinic called Dr. Cynthia Mount's clinic, Smeartalk Clinic. They're trying to absorb as much as they can. However, they have to stop accepting the patients from the refugee camp because of the sheer number of it. That's one thing. From the Burma-Bangladesh borders, we have the Rohingya crisis. There's millions and millions of Rohingya refugees is along the refugee camps, and the similar things happen. And then Bangladesh border is closed. And so as India-Burma border. But in the India-Burma border, the Mizoram, the local government, opened up for the refugees, for Burmese, and they try to provide as much as they can. It's purely for the refugees, not for control of the infections. So from China-Burma borders, Burma has a self-interest because they have a lot of border trade across. So the China's help out, I'm sure it's for their self-interest, with the Sinovac giving out loads of vaccine, testing all the people along the area. But the only thing they can do is the town, which is directly next to the Yunnan province called Ruli. So they vaccinated all the people. They tested them every week. However, the surrounding town and cities, they don't trust it. They don't cooperate with any military, the planned or Chinese or wherever, although it is supposed to be free. The immunization rate it's quite low. People don't come and immunize because they don't trust Chinese. They don't trust junta. So this problem is really, really failed. And so because we can, now that people are moving away from the town and city, so, with the help of the NGO and INGO, we can do a lot for the displaced people. But I haven't seen any massive help or anything so far. And so it was purely the local people, they organize themselves and they're giving out the healthcare as much as they can. From the WHO only engaged with the the military, and although WHO might want to help out, there is a security issue, like Professor Agassi. Who is going to give the protections to the healthcare worker to give out the immunization or to give the healthcare? Because junta itself is arresting and detaining and killing the healthcare worker, thinking that healthcare worker are the one who leads the civil disobedience movement. And start 8 months and 1 week on, there's no control. That this country is not governable by the military. So that's that tragedies and sufferings go on, and that the Gavi give out all the resource poor countries vaccinations. Burma hasn't got none. I believe that's 4th assignment to the resource poor country is COVAX program, and Burma hasn't got anything. But previous government, quasi surveillance government, had an immunization vaccine program, and we would have been immunized 30% of the populations by June if we go according to the plan. But these immunization bought from the previous government, because there's distrust among each other, these vaccines being gone to waste, or I don't know what had happened to this vaccine either. So this is this the Prof acres or the pretty lines going up, going down, they all applies to Burma, and this everything's happening in a bad way, not in a good way. So I don't see the relief of suffering soon. And then the people, Burmese people, are give us a freedom and democracy back, or they rather die. So they are so determined. So we haven't seen the worst yet. The worst is yet to come before it gets better. Thank you.
Thank you, Dr. Wu. Well, we have 6 minutes left, so I think I'm going to attempt to do a rapid fire round. So we've got one more question for each of our speakers, which I'm going to try and get through. So I'll start again with the order that we went with. Now, Dr. Wu mentioned there the sort of the vicious cycle rather than the virtuous circles that are occurring in Burma. But we had a question from Catherine Thomas for you, Dr. Ajash, talking about how it's essentially, how do you fix the roof when the sun is shining, as they say. So, we've seen how in crises systems can change and adapt really quickly. But is there an example of or any advice from you in 90 seconds about how systems can do that when they're not in crises and can make those improvements, and we can build the resilience of our system when, for example, COVID is not in the current state of crisis that it's in.
Well, I can try and do it in 90 seconds. Building on the earlier comment, I don't think this has to be a methodology for crisis, but it has to be a methodology reflecting on change over time, which can also be a sort of an after-action review of something, a new service development. How's it been going? What have been the challenges? What have been the problems? How can we strengthen it? Or if there's been some particular incident, not necessarily a major incident, but that has been challenging to the system. And so I think it's all around asking essentially causal questions, that this happened, and we often know that this happened because we were short-staffed that day, or this happened because we didn't have the right equipment available at that time. But the methodology says, well, why didn't we have the equipment available? Why was the staff not available? And if we have an answer to that question, it often leads to, well, what was the cause of that? So it's this causal loop analysis. Even if the end result, that the challenge we're looking at is not necessarily huge, it can lead us to the causal links that could have avoided this or could have made things stronger. So I just encourage that as a way of thinking about adaptation of service systems by tracing a series of causes, which often then identifies some structural issues that could be usefully addressed.
Wonderful. Thank you, Alistair. And to Peter, similar time constraint. There's actually two, so we might try and squeeze them in if we can. One is around social media, and obviously that has presented a number of negative challenges for lots of countries during the pandemic. But a question from Duncan Cameron around, has there been any positives of that? Were you able to use social media and leverage it positively in the work that you were doing? And then, in case it has a simple answer, a very technical question from Valentina, just asking why immunizations in the two graphs that you showed didn't drop as quickly as OPD attendances did. Was that something around people being willing to engage with community and primary care in a way that they weren't willing to go to hospital or something like that? See what you can do with those in 90 seconds, Peter.
So I've been struggling maybe it's my internet. Can you hear me, first of all?
We can hear you.
Okay, thank you. I struggled to hear you, but I've read a question. So one, on social media has not been used in a very good way, and it has been quite problematic. Everything that was happening in Europe with AstraZeneca and the clots and everything in the US, people read it, and but also the misinformation through social media. So managing social media has been one of our major challenges, and there was some attempt to use it, but not as much. And then on the second question, how could immunization services be continued when OPD? Because instead of having static immunization services, they were able to organize and do outreaches for immunization. That is one of the innovations that has helped to be able to continue immunization. And you remember, many people are fearing to come to hospital, but yet immunization can be done in the open. Thank you.
Thank you, Peter. And then in our final minute, I'll just ask a very simple question to San, which is, we've talked in the last question around what other partners can do, neighboring countries, WHO. For those of us who are not directly involved in a Myanmar UK health link, any advice for us on what we should be thinking about doing to help, if anything, there is that we can do the current situation with our health worker colleagues in Myanmar or the health system there?
Yes, the simple answer is transporter help. so we because we couldn't go to landed in the Rangoon airport and help out, and you know, there are about 600 doctors and nurses who are in prison, and 30 of them shot dead on the street, and a lot of the people are hiding and fear from their lives. So we need to help them through the trans-border, because we really can't go through the Rangoon. Thank you.
Thank you. Colleagues, we have reached our time, so it falls to me only to thank our three speakers for their brilliant contributions. I really enjoyed this session and comparing the different experiences, the different threats, and what that can teach us. Where there follows a break now for half an hour before the session, panel session on reflections on the world we find ourselves in, a very philosophical title, but I think a very practical discussion that will be had. And also to encourage you, whenever you do sign off for the day, to fill in the event feedback form that you will find on the platform. Without anything else to say, though, just a huge thanks. Show your thanks through the reactions. Thank you for doing that with your applause and your hearts and your whatever the party streamers are. But this has been a wonderful discussion. So thank you to our three speakers. Thank you for the audience for your engaging questions and comments in the chat. And we will see you again in half an hour.
Thanks for your sharing, Jonty.
Thank you.
Bye.
Bye.
Thank you very much. Thanks. Bye now.